Good evening, everyone. As a special request to Dr. Ajay Kher, he has agreed to take one more class on his favorite topics, salt and water electrolytes. So thank you so much again, sir, for
Sure.
taking our request and kindly take it over, sir.
Okay. So we'll be talking about salt and water. And so that's what we're going to be talking about. We'll start a little bit with the basics, distribution of water, volume, osmolarity regulation, hyponatremia, volume and water problems in steady state. As some of you might already know, I have a few of these lectures that are already on Dr. Vivek Jha's YouTube channel. So this one today is going to be slightly different, though some of the concepts will remain the same. And if anyone's interested, they can go back to those talks for some of the additional material, and then we'll have question answers at the end. So we can maybe cover things that I might skip over today or not cover in as much detail. So this is something which everyone knows. Total body water is about 50 to 60% of your weight. So if you're 70 kg, 42 liters will be total body water, 60% intracellular, 40% extracellular. And out of the extracellular, 30% of the 40, two-third, one-third is going to be, two-third is in the interstitial fluid and one-third is in the plasma. So that's kind of the standard distribution. And then you have the sodium potassium ATPase that ensures that the sodium remains in the extracellular fluid compartment and the potassium is predominantly intracellular. So that kind of sodium being extracellular is something that is important for us to remember so that we keep that in mind. So if we give 1 liter of plain water, or we give 5% dextrose, the dextrose gets taken up by the cell, and so it becomes like free water. So how does it distribute? So it will distribute across all the whole total body water evenly. And so 60% of it will be intracellular, 40% extracellular. So now if we give normal saline, again, now this has salt in it or sodium in it. So it will be restricted. The sodium will restrict itself to the extracellular fluid. And so the expansion will be in the extracellular fluid compartment only. If we give half normal saline, so we have to treat it as 500 ml of normal saline and 500 ml of D5. And so that's kind of how it will distribute. And so that's a good way of kind of thinking about a half normal saline. So if you look at the kidney has the amazing capacity of decreasing or increasing osmolarity based on our water intake. And so if our water intake is low, it will concentrate. And if it's high, it will dilute. And then it will adjust based on what our intake is. For a normal solute intake of 600 to 700 osms, the urine volume at 1200 will go down to 500 ml, and which is why the definition of in AKI or oliguria is 500 ml. And then if you get down to 50, you can go up all the way to 12 to 14 liters of urine output based on a normal solute intake as well. And so what is important to note is that hyponatremia is water retention and is predominantly due to impaired water excretion, and that ADH is the main defense against hyponatremia. And thirst is the main defense against hypernatremia. And so we'll go over a little bit of these things during the talk as well. So if you take home anything from this talk, I think this is the slide that I would want you to kind of keep home with you. And that is that osmolarity regulation is very different than volume regulation, and that they're both regulated separately. And so the disorders of one need to be thought about separately, and the disorders of the second need to be thought about separately. So let's talk about osmolarity. So osmolarity or sodium concentration is sensed as plasma osmolarity by the hypothalamus osmolar receptors. And if it senses hyper osmolarity, then it will cause ADH to be secreted, and it will cause you to be thirsty. ADH will cause water reabsorption, and thirst will cause water intake. And so once the water goes in, it will dilute you down, and your osmolarity will come back to normal. If your osmolarity is too low, ADH shuts down, thirst shuts down, water excretion happens, water is excreted, osmolarity comes back up. If there are problems with any of this access, you will have hyponatremia or hypernatremia. And so those are problems of water and not sodium, because the effectors of hypo and hypernatremia, or how the body senses and how it regulates, are through water excretion and water intake. And so it is important to recognize and kind of always think in mind: hyponatremia, too much water; hypernatremia, too little water. And nothing about sodium, which is unfortunate that the name has sodium in it, but these are water problems. So now you think about volume regulation. And so volume regulation, or the total amount of sodium in the body, is sensed as effective circulating volume by the carotid sinus, afferent arterial atria. The effectors from these are the renin-angio-aldo system, the natriuretic peptides, and the sympathetics. The ADH is a very late effector, and we'll go into when and how ADH gets revved up for volume regulation. In addition to causing some vasoconstriction, the main long-term impact of these are urinary sodium excretion. So either increase or decrease of urinary sodium excretion. And the problems or disorders that we have in volume are either volume depletion or edema and volume overload. And so these are problems of actual too much sodium or too little sodium in the body. So if you have volume depletion, there's too little sodium. If there is edema and volume overload, there is too much sodium. So these are actually sodium problems, because the long-term impact, or the way the body controls volume, is through sodium excretion. So how does body's ADH? So on the y-axis is ADH levels, and on the x-axis is the percent change. These white circles are isovolumic osmotic changes. So small changes in osmolarity, you have very linear and rapid increases in ADH. And so that's what this clear circles are indicating. And the dark circles are volume changes. So if you cause volume depletion for the first 6, 7, 10%, there is very little change in ADH. However, beyond this 7, 8%, ADH can go up very rapidly and exponentially for any further decrease in volume. And so the way to think about it is like the body's evolution over the evolutionary pathway is that if there is significant volume loss, then as a last ditch effort to save the organism, ADH is also revved up to retain as much water, as much salt as possible. So whenever you have volume loss, the first, even at this stage, your renin-angio-aldo, your sympathetics are all revved up. Only as a last ditch would ADH rev up, and that is as a last ditch to save the organism. So now let's talk about a few cases of hyponatremia, which is the most common disorder, electrolyte disorder, and something that is searched most often on UpToDate and most questions asked. So let's look at a 55-year-old male with cirrhosis from alcohol, and he's presenting with a scheduled endoscopy. He's noted to have an asymptomatic serum sodium of 128. The serum osm is 260, urine osm is 450, and the urine sodium is 80. And the patient is not on any diuretics at present. So what is the cause of hyponatremia? So it could be cirrhosis, in which the mechanism is effective circulating volume depletion. You can have bare potomania, you can have SIADH, or you can have true volume depletion. So we'll go through a few cases and I'll share my approach of how I think about hyponatremia and how to delineate the causes. Or there are other approaches which use the same components but combine them differently. So the first thing to look at is serum osmolarity. So if the serum osmolarity is low, then you know that this is hypoosmolar hyponatremia or true hyponatremia. If the serum osmolarity is normal or high, then it is pseudo hyponatremia. and it can also be hyperglycemia. So pseudohyponatremia would be either too much protein or too much lipids. If it is low, then the next step that you have to do is to look at the urine osmolarity. So if you have hypoosmolar hyponatremia, the body's response should be at the ADH level to shut down ADH. If the ADH is shut down, then the kidney should be putting out urine at an osmolarity of less than 100. If it is doing that, which is what is happening here, then what it means is that you're overwhelming the body's capacity to dilute urine and drinking too much water for the amount of solutes. So if you're eating a normal solute intake, you have primary polydipsia, which would mean that you are drinking at least 12 to 14 liters every day. Or you can have this beer potomania and tea and toast, which means that your intake in terms of solutes is very low. And so even a normal water intake of 2 to 4 liters can get you into trouble with either beer potomania or tea and toast. And again, when we are talking solutes, we are talking only salt and protein. Carbs and calories don't count because that's what the solute that is going to be in the urine. So that would be the normal response. If the urine osmolarity is more than 100, what it means is that ADH is present. So for the example, the case that we're talking about, his serum osmolarity was 260, so he is hypoosmolar. His urine osmolarity was 450. Now that you know that ADH is present, then the next step is to look at whether it is appropriate or inappropriate. And for that, you can use urine sodium. So the urine sodium in the setting of a true volume depletion or an effective volume depletion would be low because the renin angioaldo system would have been revved up long before ADH actually revs up. And so the urine sodium would be less than 20. Then that means that there is either volume depletion or effective volume depletion, which would be cirrhosis, heart failure, nephrotic syndrome. So those would be the reasons why you would have a low urine sodium, but a high urine ADH and a high urine osmolarity in the setting of hyponatremia, or that is actually the cause of the hyponatremia. If the urine sodium is more than 40, like in this case, it is 80, then what it means is that there is SIADH. And so this is inappropriate ADH because there is no volume related stimulus. Because if there was a volume stimulus, the urine sodium would be low. Before you label someone as SIADH, make sure you check the hypothyroid and cortisol levels to make sure that TSH and cortisol levels to make sure that that is not a cause for their SIADH. And in case someone is confused as to true volume depletion or effective volume depletion, the exam, all those with effective volume depletion, heart failure, cirrhotics, will be massively volume overloaded with edema and those kind of presentations, while volume depletion will be hypotensive in shock with poor skin turgors. So the answer for this case is SIADH. And so when you went into the story of this patient, turned out that they had recently started fluoxetine for depression. And when we stopped it, the hyponatremia disappeared. So another patient who's a 24-year-old male with alcoholism presents to the emergency, being found down, has a blood pressure of 120/80, pairs euvolemic, serum sodium is 128, serum osmolarity is 265, urine osmolarity is 60, and urine sodium is less than 10. So is this pseudo-hyponatremia, beer potomania, volume depletion, or SIADH? So again, we'll go back to our algorithm, and the serum osmolarity is the same as last time, so 265. Urine osmolarity is this time low, so you know that this is someone who is brain is appropriately responding, ADH is appropriately shut down, and the kidneys appropriately responding with a dilute urine. And so this is either primary polydipsia or beer potomania. This is an alcoholic. So you know that this is beer potomania. And so the low urine sodium is due to the very dilute urine. So the osmolarity is only 60. So even if you have a 20 sodium, there would be 20 chloride with it. And so that would give you an osmolarity of 40. So when you have an osmolarity of 60, the amount of sodium in the urine will be very, very low. And so that is what's going on here. And this is not a reflection of any volume depletion state in this situation. So now what happens when we are talking beer potomania, and how does solute interact and control the urine volume in these situations. So if you have a normal intake of 600 osms, you have a water intake of 1 liter, the body will adjust the ADH level and the urine osmolality will be 600 and you'll put out at 1 liter. So now let's say we drink 2 liters with the same intake. So 600 osms, you have 2 liters of water intake, ADH is going to be lower, your urine osmolality will be now 300 and you'll put out the 2 liters that you take in. Let's say you drink 6 liters on a day. Again, your solute intake's the same. You have 6 liters of intake. ADH is going to be shut down more. Your ADH urine osmolality will be about 100 to put out the 6 liters. In beer potomania, what is happening is that your intake is very, very low. So let's say you have only a 200 milliosm intake, and with the beer, you're drinking 4 liters. So even at 100, the maximum that you can get out is 2 liters. And so the remaining 2 liters are now going to be extra in the body, and that is what is going to cause the hyponatremia. And you will need to continue to do this every day, because at any day you do a normal intake with even 5 or 6 liters, the body will be able to get rid of the extra fluid as well. In primary polydipsia, you have a normal solute intake, but you have to have an excessive water intake of about 14 liters. And depending on whether you're at 50 or at 100, you'll put out somewhere between 6 to 12 liters, and the remaining water is going to be extra. And so that is what is going to drive the hyponatremia and then maintain the hyponatremia. So take home is that beer potomania or tea and toast is too much water intake for the small amount of solute intake. So this is an 89-year-old male who falls on the side of the road, coming out from watching a movie. He's brought directly to the emergency and noted to have an impaction type femur fracture, and also has a previous heavy smoking and COPD history as well. The serum sodium is 123, serum osmolarity is 260, urine osmolarity is 290, and urine sodium is 73. And so we've put in two causes of SIADH, pain or another cause. So pain after the fracture can also be a cause of hyponatremia, or SIADH and then hyponatremia. And so the question is whether the heavy smoking and COPD or something like that, or a cancer is the cause, or this. And so going through the algorithm, so serum osmolarity is low, urine osmolarity is high, ADH is present, urine sodium is high. So this is SIADH. So the question is, in this case, it is lung cancer, because if you have someone who fell and hasn't had any water intake, then unless you take in more water than you're putting out, you can't develop hyponatremia. So in this case, as soon as he fell, he came to the emergency and his sodium was already low. So the pain, whatever pain he's having, could cause SIADH, but that SIADH would take time and the hyponatremia would have developed during his hospital stay, not at presentation. So if he has SIADH and hyponatremia at presentation, the water intake that was there had happened before. And it is likely that the hyponatremia is the cause of the fall and the cause of the fracture in this situation, rather than a consequence of it. So what it means is that we need to look for causes in these situations if the water intake and things are not there before. So in SIADH, so again, we've looked at the normal, and now just to look at what happens in SIADH. So let's say someone's taking 600 milliosms and has SIADH. In this situation, let's assume that the urine osmolarity is now fixed at 200. In this situation, with 600 osm intake and a urine osmolarity that is fixed at 200, they'll put out 3 liters and they're going to be negative 1 liter in this situation. And so there isn't going to be any hyponatremia that will develop. They'll feel thirst and they'll take in more water, and they'll even out this 3 liters to the 3 liter output to 3 liters intake next time. However, if their urine osmolarity is stuck at 400 due to the ADH, they will put out the 600 osms in 1.5 liters, and they'll be half a liter extra. If their urine osmolarity is fixed at 600, they'll put it at 1 and have a 1 liter extra. And if it is at 900, they'll put it out in 2/3 of a liter and have 1.3 extra. So the reason it's important is because when we treat these, Also, it's important to know how much intake, solutes, as well as urine osmolarity is to manage them as well. So we'll take a couple more cases and then we'll switch things. So a 60-year-old male with lung cancer presents with nausea and vomiting. Blood pressures are 80/40 with dry mucous membrane. Serum sodium is 124, serum osmolarity is 260, urine osmolarity is 600, and urine sodium is less than 10. So what's the cause of his hyponatremia? Volume depletion, the cancer and SIADH, both of them, or cannot say, and will reassess after IV fluids. So again, it's mostly a question that I would want to highlight certain things. And so the answer actually is cannot say and reassess after IV fluid. This person is volume depleted. They have low turgor, they have a reason, they have dry mucous membrane, and their urine sodium is less than 10. So there's no doubt that this person has volume depletion. But the question is the hyponatremia due to the volume depletion or due to something else? And so the proof is going to be what happens after you give IV fluids. So let's say we've given 3 liters of normal saline and then we repeat and look at his labs. So this is what will happen. So let's say we'll start with the rightmost column and say, let's say this is someone who has persistent volume depletion even after we've given 3 liters. But the cause of the hyponatremia was the volume depletion. So serum sodium would have improved, the urine osmolarity will lower, and the urine sodium will be less than 10. And so the reason is because the ADH would come down on the axis. So as you lower the volume depletion, the ADH levels will come down. The serum sodium will improve because the ADH levels come down, and the urine sodium will remain less than 10 till we have completely corrected the volume, which is the middle column. So if we have completely corrected the volume depletion, serum sodium will improve rapidly. The urine osmolarity will come down to less than 100, because as soon as you get below this 5%, 6% volume loss, and you're very close to their natural volume, the ADH will shut down. And once you've completely corrected the volume, the urine sodium will go up to 40. If you've only partially corrected it, urine sodium will still be less than 10 because your renin-angioaldo is still active. As soon as the renin-angioaldo shuts down, the urine sodium will come out at more than 40. If it is SIADH, then the serum sodium will remain unchanged. The urine osmolarity will remain unchanged, but the volume depletion will correct. And so the urine sodium, which was less than 10, will now be more than 40. So if after 3 liters of normal saline, you see the urine osmolarity is still high and the urine sodium is corrected, you know that the cause of this person's hyponatremia was actually SIADH and not the volume depletion. So now we'll talk a little bit about tolvaptan. So you have a 35-year-old asymptomatic alcoholic cirrhotic who's admitted for the endoscopy. Serum sodium is 115. Despite 2 days of fluid restriction of 1 liter, he's not improving. Urine osmolarity is 200. What should be the next step? So should we start tolvaptan and continue fluid restriction? Should we start tolvaptan but stop the fluid restriction? Should we give protein supplementation and really restrict his fluid to 1 liter? Or should we admit and give him 3% hypertonic saline? So we'll go over a few of these and talk a little bit about tolvaptan. So tolvaptan or V2 receptor antagonist. And so this is SALT-1 and SALT-2 trials. And so the circles, the white circles are people on tolvaptan. The dark squares are people who are placebo in this. When you give tolvaptan, you can and will increase their serum sodiums by about 5 compared to what they were on placebo in SALT-1 and SALT-2. Those who had marked hyponatremia with an average of 125, they also reached an average of 135 after about 15 to 20 days. However, as soon as or whenever you stop their tolvaptan, so this is the lines here, their hyponatremia returns and they come back to all the point as if they were at placebo. So what it means is that it is effective in raising sodium. In SALT-1 and SALT-2, they appear to be safe. However, the effect lasts only while you're taking the medicine. And in this trial, as well as in other trials with hyponatremia, there is no mortality benefit. And whether there is any improvement in quality of life was unanswered in this and other trials. So how did they use the tolvaptan? There was no fluid restriction. or other treatment for hyponatremia when you start tolvaptan. So this is something which is very important to remember, that if you are starting someone on tolvaptan, make sure you get rid of all the other treatment that you've done to ensure you don't overcorrect. Watch for overcorrection and stop if you overcorrect. Even in SALT 1 and SALT 2, about 2% of patients had rapid correction and 2% had a sodium that went up to more than 146. It was not used for patients who had a sodium of less than 120 with symptoms. So anyone who's symptomatic hyponatremia needs 3%. Everyone was hospitalized at initiation, so this is not an outpatient treatment. And the diseases were SIADH, cirrhosis, or heart failure. If you have hypovolemia, polydipsia, head trauma, post-op, or like an SSRI that you can withdraw, do not use tolvaptan. And again, it did people who had advanced kidney disease, whether it was acute or chronic, with a creatinine of more than 3.5, were not put on this. There is a caveat that we should be monitoring LFTs, though the predominant literature on liver dysfunction is actually from polycystic kidney disease, where the doses of tolvaptan are much higher and for a longer duration of time. So this is a study which was published in 2017, and this is from Otsuka, which makes tolvaptan. And what they did was they looked at healthy adults and gave them 15, 7.5, and 3.75 milligrams of tolvaptan. And then they gave SIADH patients the same 15, 7.5, and 3.75, 10 patients in each arm. A single oral dose caused a rapid increase of more than 8 in 8 hours or more than 12 in 12 hours in 1 out of 10 in each of these doses. So 1 out of 10 in the low dose, 1 out of 10 in the 7.5 dose, and 2 out of 8 in the higher dose. So for a total of 4 in 28. And while in the SALT trial, the overcorrection with first dose was 6% and overall was about 2% of more than 12 in 12 hours, or more than 12 in 24 hours. And so if you even give small doses in SIADH, the first response can be 10 to 12% overcorrection. And so this is what happens in real life. So that was a study that was done by Otsuka. This is a study which looked at data from 5 US hospitals in which there were 28 SIADH patients, 39 heart failure patients who received tolvaptan in the setting of a sodium of less than 130. Anyone who had other treatment that was going on, whether it was water restriction or salt therapy, were removed from the study. And what they looked at was the correction rate. And so those who did get tolvaptan had a 25% chance of having an overcorrection of more than 12 if you had SIADH, and about 3% if you had heart failure. So it's very important to be aware that you can have overcorrection with tolvaptan, and so it's important to be aware of that. Tolvaptan versus urea. So urea tablets are available in France, and so this was a study done by Supat there. And what he did was people who were on tolvaptan in a study and then had the study had stopped, and so they were going to get withdrawn from the study, and tolvaptan wasn't going to be available for them. So all of them had normal sodiums while on the tolvaptan. They stopped the tolvaptan, saw them develop hyponatremia, and then he gave them urea tablets. And with the urea tablets, they came back up. So again, urea tablets or protein supplementation or salt supplementation, if it is SIADH, are ways of giving extra solute, and that can correct your hyponatremia as well. So that's what this study proves. So again, so take home for Vaptans is they work. Careful when, where, and how to use them. I personally rarely use them, and I'm able to manage almost all of my patients with some combination of salt, protein, supplementation, fluid restriction, and furosemide. So the real answer for this patient is to give protein supplementation and really restrict the fluid to 1 liter. So now we'll talk a little bit about combinations of diseases. And so volume and water, and when you have combinations, how do you approach them? So 60-year-old male with 60-year-old 80 kg male with heart failure, pedal edema, pulmonary edema, and we are assuming has about 10 kgs extra, gets intubated on arrival, and gets a Lasix drip started. Urine output is about 150 an hour. Initial sodium on the first day was 140. Next day is 146. Diuretics are continued. He has another 3.5 liters of urine output. And the next day, the serum sodium is now 153. How do you treat him? You stop the diuretics. Do you stop the diuretics and give free water? Do you continue the diuretics and don't give free water? Do you continue diuretics and give free water? So how do we kind of approach these patients is first we label them as what's their disorder from the volume standpoint as well as the water standpoint. So this patient still has volume overload, which is what they came in with, and they have hypernatremia. So when you think of volume overload, too much salt in the body. When you think of hypernatremia, too little water in the body. And so you can approach and treat both of them and target both of them. So for the volume overload, you will continue to use the diuretics. And for the hypernatremia, you're going to give free water. So if we continue the diuretics and we assume that we are going to get the same response, you'll get a 3.6 liter output, and we give free water. So we give free water for the urine output, which is going to be 3.6 liters of urine output, out of which half is going to be free water, half is going to be the salt rich urine. And so we'll take 1.8 liters for free water plus 500 for the insensible. And let's say we want to correct the serum sodium by 16. So then we'll get 1.2 liters. And so total would be about 3.5 liters of water that we want to give. And that will correct these sodium over time. In this scenario, even though the person is getting 3.5 liters of water in and 3.6 liters of urine output, their extracellular volume will still be negative because the free water, 2/3 of it will be going intracellular and only the remaining 1/3 will be extracellular. In comparison, the urine output and the sodium that is coming out will be large part coming out from the ECF volume. So now we'll take another patient, an 80-year-old man who has Alzheimer's, is brought from home for being drowsy, not responding, diarrhea for 3 days. And we see a thin cachectic gentleman with a weight of 60 kg, blood pressure is 110/60, minimally arousable. He has poor skin turgor, lab shows serum sodium of 175. So how would you treat him? Normal saline plus D5, half normal saline, or just D5. So again, let's go back to dividing his problems into the volume and sodium problems. So he has volume depletion and has hypernatremia. So for the volume depletion, we need to replete volume. For the hypernatremia, we need to give water. And so we can treat him with the combination of either 1 liter kind of normal saline at 100 ml per hour after a bolus if you want, and the D5 for the hypernatremia. If we do want to treat with half normal saline, that's also okay because you can give half and half, but the rate would need to be much higher. And so that's why the answer for this is B, normal saline plus D5, and half NS if we wanted to use, we can. And then we would need to increase it to 200 ml per hour. And as we treat him, we would need to be aware that we may need to split them apart because it might be that the volume corrects and is corrected completely, and then we don't need to need NS at all, and then switch to just D5, or the hypernatremia is correcting more rapidly, and then we might need to just use NS. So another patient, 50-year-old female coming in with vomiting, diarrhea, and hasn't been able to take any liquids, blood pressure 70/40, poor skin turgor, and labs show a serum sodium of 120. So how would you treat? Normal saline, 3%, 0.45, half normal, normal, and 3%. So again, looking at her disorders, so she has volume depletion and hyponatremia. Volume depletion means too little salt, so we do need to give and correct the volume. Hyponatremia means too much water. And in this situation, because we know or are highly likely that this hyponatremia is due to volume, as you correct the volume, the ADH will shut down. As the ADH shuts down, the urine will become dilute and the hyponatremia will correct as well. So in this situation, actually just the normal saline by itself will fix both the volume and the hyponatremia once the ADH drive shuts down. So the last one in this group is going to be 45-year-old male with diabetes, ischemic heart disease, EF of 20, shortness of breath, swelling in the legs, chest has creps, extremities have 3 plus swelling, all the way up to the thighs. Lab shows serum sodium of 125, blood sugar is 150. How would you treat for both the hyponatremia and the volume overload? 3% saline, saline and furosemide, furosemide or furosemide and normal saline. So again, this person has hyponatremia and volume overload. So for the volume overload, we are going to continue to diurese, and because the urine output from Lasix or diuretics is like a half normal saline, many times that by itself will correct the hyponatremia if we ensure that the water intake for the patient is restricted and the fluid is restricted, while ensuring good solute intake from protein, because we can't give sodium. So many times just furosemide might be okay, or furosemide plus water restriction, maybe with some protein supplementation. So now we'll talk a little bit about steady state. This is something which is not usually covered as well in most situations, but this is something which is important for us to remember whenever we are looking at a balance in the body. So these are some of the classic studies, and this is from, you can get it in Up to Date, or it's in Bud Rose's book. So this is the weight on the top at 70 kgs. This is sodium intake. So this sodium intake is somewhere around 20 MEQs per day. And they increase the sodium intake from this 20 all the way up to 150 MEQs per day. So as you increase the salt intake, what ends up happening is you're going to have extra salt, which will cause your extracellular volume to go up. And so your weight is going up over the next few days up to 71. And there is this extra, your urine output as well as your urine sodium output is increasing, but it lags behind the total intake. So you have this area of positive sodium balance that is happening till after 4, 5, maybe 6 days, depending on the increase, you're going to be in steady state. At this steady state, even though you're taking 150 MEQs of sodium every day, the body is excreting 150 MEQs every day. And the weight is not going to go up above 71 because you're now in steady state. Whatever you're taking, you're putting out. So at 20, you were at steady state, and you're taking in 20, putting out 20. Now here also you're at steady state, which means the body with just this 1 kg increase in weight is recognizing the extra salt that you're taking every day and is excreting that salt every day. If at the end of this, you go back to what you were doing before, there'll be this negative balance because the urinary salt excretion will lag behind the cut down in the intake, and this extra salt that you had will come out, and you'll go back to your original weight of 70, and your extracellular volume will go back to what it was. So in this situation, what ends up happening is you have sodium excretion forces and sodium retention forces there in balance. When you increase your salt intake, the excretion forces start increasing, and you increase your urinary sodium excretion till you come back in balance. And once you come back in balance, then you excrete all the extra salt that you're taking. This is same is true with thiazide diuretics also. So if you look at this, in gray is sodium balance, this red is potassium balance, and after a few days, you are in sodium balance. So by 4 day 5, you're in sodium balance. And for potassium, it takes about a week for you to be in potassium balance. So if you take a particular dose of thiazide, whether it's hydrochlorothiazide, chlorothalidone, after 7 to 9 days, your sodium and potassium are back in balance. You may have a lower sodium or a lower potassium for that dose of thiazide, but it is now in steady state. So if you started someone on a particular dose of thiazide, after 7-10 days, there isn't going to be any further variation or change. So if you have someone on thiazide at, let's say, 12.5, 10 days later, they don't have hyponatremia or hypokalemia, and then 3 months later or 6 months later or a year later, they have developed hyponatremia or hypokalemia at that dose of thiazide, the thiazide is not to be blamed. There is something else that has happened that we need to look at, find, and diagnose, and that is what is the cause. So any hyponatremia or hypokalemia that's developed will happen within the week. If it's beyond it, something else caused it. The same is true for loop diuretics when you give bolus dosing or infusions. So this black line is an infusion. The bolus dosing are dotted lines. The first dose you give, you're going to get a much higher response. The second dose is going to get you a lower response because now you've had the sodium retention forces are going up. So you were in steady state, you give Lasix, which is the causing sodium excretion, and that is going to drive your renin angio-aldo. Your sodium retention forces are going to go up. You're now going to start to retain salt, and you're going to come back into balance. Another aspect of intake is, as we talked about, solute intake. And so this is important when we look at or talk about SIADH and how to treat those. So we'll come back to this. So this is the same example of intake. Solute intake is 600 osms. You're taking 1 liter, body ADH goes up and down to adjust and puts out urine at 600. If you take 2 liters, osmolarity will go down to 300. You take 6, it's 100. Now you have SIADH, 3 liters, output at 200 osms fixed, 400, 600. If I give Lasix to someone who had a urine osmolarity fixed at 600, we are going to get isoosmotic. And so when we give furosemide or Lasix to someone who has SIADH, we are now blocking them at 300. If they're taking 2 liters of intake with a normal solute intake of 600, they're going to put out 2 liters instead of the 1 liter that they were doing at 600. At this situation, they were gaining 1 liter every day. With the Lasix, they're now even every day. Now, if with the Lasix I add fluid restriction or I add the extra salt or urea or protein, so now I've increased their osmolarity to 900 in a day. They are taking water at 1 liter by the fluid restriction. And even if they're 600 osmolarity fixed because of SIADH, they'll be negative. In diabetes insipidus, which is the reverse, you have someone who's taking a normal 600 osm intake and the urine osmolarity is now fixed at 100. So they're going to be putting out 6 liters. And because of the thirst, which is their defense mechanism, they're going to drink 6 liters also. In this situation, if I cut down their osmolarity and say, put them on a low salt diet or a low protein diet or a combination of those, and now there are 300 osms, even if I don't do anything to their DI, the urine output goes down drastically. They're now putting out only 3 liters. And because of this, they're only needing to drink 3 liters. So if someone has DI, one, you can give them vasopressin depending on whether it's central or nephrogenic. But another aspect or another component of their care can be decreasing their solute intake, which will also decrease their polyuria. So as we said, thirst is the main defense mechanism. So this is where ADH revs up, and then this is where thirst revs up. And even in patients who have diabetes insipidus, they will not develop hypernatremia that is significant or will show up on our labs because someone's going to defend their serum osmolarity through thirst. So in this, if their urine osmolarity is going to be less than 100, if their ADH is shut off. In central DI, you may excrete 10 liters per day, but the serum sodium will be near normal. And symptomatic hypernatremia will not develop in any patient if they have an intact thirst and can get their hands on water. So the reason people get hypernatremia in the patients that I shared is because they were elderly, they were in the ICU or in the hospital, and they weren't able to get their hands on water. If you ask any of those patients, do you want water? They will really scream for water if you ever ask them. So the mechanism of hypernatremia is that as long as you're awake, able to get your hand on water, no hypernatremia, you will need water depletion and an inability to get water. So you can have insensible losses, fever, sweat, or ventilator, GI, diuretics, osmotic diuresis, or you can have central or nephrogenic DI. Any of these can be causes of how you're losing the water, but you also need an inability to get water. And then you have the hypothalamic lesions, in which you could either have loss of thirst, or you could have a reset osmostat as a reason for hypernatremia. So coming back to the key concept that I would hope that you guys take with you, osmolarity is sensed by the osmolarity receptors. ADH and thirst are the effectors, and they control by water excretion and water intake. And the disorders are hypo and hypernatremia. So if you have hypohypernatremia, think of too much water, too little water, and that this is a water problem. Volume regulation, regulated through the effective circulating volume, through the carotid sinus afferent arterioid atria, through the RAS, natriuretic, and the sympathetics, and predominantly what they're controlling is urinary sodium excretion, and your volume depletion or edema and volume overload as your problems. And so the conclusion is I would like to thank everyone for listening, and I'm happy to take questions. I've intentionally kept 10-15 minutes there, and these are the three sodium talks that are on Dr. Jha's YouTube channel. So if you want 3 hours of salt and water, you can go through these three, and it'll have more details as well. And I'm happy to take questions. And I'll try and see if I can see the questions also. Let me see. You can post in the chat and I'll try and answer those, or you can raise hand and we'll see if I can, I don't know, if muting and unmuting is possible also.
Yes, sir, they can do that, sir.
Sure. So
Um,
either way,
sir, can I ask it out?
sure.
So that case where the patient had volume overload and along with it had along with it had the first
Hypo,
case, uh,
okay.
uh,
This one.
this one 153
Yes.
sodium along with it
Yes. And had volume overload.
volume overload. Yeah.
This is standard heart failure patient. You will see this every day of your week. If you're in a cardiac unit, this is every day.
With this, sir, wait, I'm just, can you just give me a second, sir?
Sure.
So how will the patient get better even though like we're giving them
Yes.
that much of
Yes.
fluid?
Yes. So this is what we are talking about. You are giving them 3.5 liters of water,
Right,
plain water. They're
right,
putting out 3.6 liters of urine.
right.
Their extracellular volume will go down. So the reason it will go down is comes back to this. So when you give 3.5 liters of water,
It all goes intracellularly and
majority 60-70%
yeah,
will be intracellular,
yeah,
and the remaining 30-40% will be here. What
right,
you're putting out is going to be 50-60%, means it's going to be like half NS. So 50% will be like free water and 50% will be NS. The 50% NS is coming completely out of the extracellular fluid, and the remaining 50%, 60% will be coming from here and 40% from here, or
right.
two-third, one-third. So even though you are net even on weight, your
Yes.
extracellular fluid volume is going to be coming down.
By just say 100 ml, right? Or so.
So we can do it's probably going to be more than that. We can do the math in exacts also, but it's going to be not just 100 ml. It's going to be significantly more than that, because the distribution would be in 60% and that.
Sir, on top of this, suppose this patient has some renal dysfunction as well, and
Sure.
is requiring dialysis or say ultrafiltration, how would you then go about this? Like because this is a common thing which we see in our
Sure. So
this.
if someone has hypernatremia and volume, you would still want to ultrafilter them if they're on dialysis. So let's
Right.
say you have a hypernatremic dialysis patient who
Yeah.
is now going to get volume removal also. So you would still volume remove them. The
Yes.
sodium on your dialysis machine will be lower, and so
Yes.
there will be a water exchange or a water gain that the patient will have while the sodium is coming down. So on dialysis, the sodium will come down, the volume will be taken out separately. So on this, you're correcting both of those, the volume overload and the hypernatremia, or even hyponatremia for that matter, in on dialysis, with your dialysate sodium being either 135. So if you're 120, it'll move it up. If you're 150, it'll move it down, because they will gain that water
Mm,
from our dialysate.
dialysis. And
Yeah.
so, wouldn't we be pushing them further in edema, pulmonary edema? No.
No, because you're doing ultrafiltration, and in the ultrafiltration, the dialysate
US.
sodium, the ultrafiltration sodium will be 120 or 150, whatever sodium is in the blood.
Yes.
So the 4 liters, let's say you do 4 liters of ultrafiltration, that 4 liters of ultrafiltration will have a 130 or a 140 sodium in it,
Sodium. Yes.
compared to urine, in which the urine osmolarity, urine sodium is about 75 to 100 in a Lasix urine. So if you do Lasix urine, it's usually half NS kind of a urine.
Okay. So,
And so
so, so we will have to give them free water alongside. Yes.
if you're on dialysis, depending
Yes.
on how much dialysis and how much time, you may end up needing to give them some free water, because you may not completely correct. Plus, all these calculations that we do are based on current. They don't take ongoing losses. So whatever caused this person to get hypernatremic, unless you fix that, they will get hypernatremic again in next 24 hours. So even if I correct them, unless we so let's say they are getting no water access at all. They aren't on RT feeds. They're not
Mm,
getting any water, and so they will get hypernatremic again. So you
again.
to make sure that you're giving at least some water, but it might be that you're now at 140, so you just need to give replacement.
All right. Thank you, sir. Thank you so much.
So there's a couple of questions. Will tolvaptan be effective in CKD? So again, the worse the creatinine, the worse the diluting capacity or the concentrating capacity of the kidney. And so there is a nice curve that is there in many of the books, where as you get worsening kidney disease, you start getting more isoosmotic, and so the urine osmolarity can't dilute, can't concentrate, and you're somewhere between 200 and 400. And so even tolvaptan won't be able to decrease it much, unless your mm, uh, kidney disease is only mild or early. More advanced kidney disease, it won't work. So another question is, many patients with SIADH are or have multiple comorbidities that they can't increase protein intake. I don't think there is any restriction to increasing protein intake in any SIDH. They don't want to eat, they can't eat, they are feeling sick, they're in the hospital, our hospital food sucks. So all of that is going to be true. So usually I am very liberal with protein supplements and pushing my dietitian to give them all the protein or whatever they like. You can increase sodium intake for patients with SIDH. That's not possible for patients with cirrhosis or heart failure. But all SIDH patients, you can put them on a high salt diet, and that will also increase their solute intake. The sodium that we give doesn't stay in the body. So again, this is an important point I would want to highlight as well. So the sodium that we give is going to come out in the urine, because their volume regulation is absolutely fine. They have SIADH, their ADH is a problem. You give extra salt, that extra salt is coming in the urine. So how does it help their hyponatremia? It gets extra water out with it. And so that is how in SIADH, giving extra salt helps someone with hyponatremia. And so concept of bolus dosing for correction of acute symptomatic hyponatremia. So if you have acute symptomatic hyponatremia, you can correct rapidly for the first 4 hours. And because you have cerebral edema, because this is symptomatic hyponatremia, in that situation, because there is cerebral edema, you can give 100 ml bolus of 3%, or you can calculate if you want and give something that corrects them rapidly, 3 to 4 MEQs or 4 to 6, depending on how serious you think the symptoms are. And after that, you still want to be overall below 12, though there are now studies looking at how bad the osmotic demyelination rates are. And so there is some move towards lifting how much or how quickly you want to do the correction. But I would still be hesitant and cautious, and I would correct slowly because osmotic demyelination, if you get even one, there isn't any going back. And so there's no reason to correct too quickly in this situation as well. Any other questions? You can feel free to put in the chat or kind of ask.
If there are no more questions,
Okay,
can we
I
thank
think
sir?
okay, so there's one last one, I think.
Yeah.
What is your opinion about Lasix infusion versus bolus dosing? So I didn't talk about it intentionally, but I'll show you the graph again. I am a very big believer in Lasix bolus not being as effective as Lasix infusion. So if you look at the area under the curves when you have an infusion, the area under the curve is going to be better, and you will have more salt removal by a drip than bolus dosing. And this is also in, if you look at the heart failure study in which they used bolus versus Lasix, the overall outcomes were similar in terms of efficacy of removal, but you ended up needing more milligrams of bolus Lasix, and you had more number of patients that needed an increase in the Lasix dose compared to those who were on infusion. So I do believe that infusions end up milligram per milligram getting more salt removal and more edema loss. Any effect of SGLT2 inhibitor on serum sodium? So again, the defense against hypernatremia is thirst. And so even though SGLT2 inhibitors will cause some water diuresis from their sugar load and excretion, and we do know that there are some weight losses from it, they shouldn't be, and there hasn't been any serum sodium significant increases to cause hypernatremia, because their defense is going to be thirst. Chronic SIADH management. So again, I would first do the urine osmolarity. If the urine osmolarity is 300 and below, fluid restriction, extra salt, extra protein works. If you're above 600, you're going to need furosemide as well to lower them to 300, and then the fluid restriction, salt, and protein will work. The furosemide that you need is very low dose because they don't have renal dysfunction, heart failure, or liver dysfunction, which are reasons why we usually end up needing to use high doses of furosemide or torsemide. Even 5-10 mgs of torsemide or 20 mgs of furosemide once or twice a day would be good enough. So patients of CKD on dialysis with symptomatic hyponatremia, will dialyzing help, or do we try correct with bolus 3%? So again, hyponatremia that is symptomatic in a dialysis patient is really uncommon. If you do have someone who's symptomatic, I would bolus them. Dialysis, the problem with dialysis will be controlling the rate of correction on dialysis for someone who's symptomatic will be very, very hard. And usually symptomatic would be 110 or maybe even less than 100. And in these situations, controlling the rate at which your dialysis is going to correct is going to be very hard. You may end up actually wanting to do CRRT or small dialysis sessions only, and then doing an hour session or something, because you can't lower the serum, so the dialysate sodium too much. So if there's symptomatic hyponatremia, I would do 3%. And unless there was another indication for dialysis, I would postpone their dialysis for another day or two as long as I can. Tolvaptan in kidney transplant. So again, haven't used it. I'm not sure what indication there would be for using tolvaptan. Like I said, I'm not a big fan and I don't use tolvaptan that much, even for hyponatremia. And I have used tolvaptan for ADPKD. And so most of my tolvaptan usage is in ADPKD and not in hyponatremia. But I don't think I would use it for someone with kidney transplant, though I don't think there are any interactions with immunosuppressants. How can we correct sodium in CRRT patient with a serum sodium of 175? So if you have to do CRRT, the reason to do the CRRT would not be the serum sodium. Again, if I have someone with a serum sodium of 175, I want to correct them, I would rather correct them with plain water or D5 and control it that way. CRRT, again, is not going to be easy to control the rate because you are limited in the bags and the concentration of fluids that are available to you. If you are doing CRRT for other indications other than the hypernatremia, what you would need to do is probably do the CRRT at a very slow rate. Second, you could combine it with 3% that you're giving separately, where the rate of the 3% you can calculate based on the rate of the CRRT fluid that you're running, and then monitor closely as you correct that. Sir, if we supplement NS and 5D for hypovolemic hypernatremia, will it worsen hypernatremia? Okay, so if there is hypovolemia and there is hypernatremia, you can correct them separately. The hypovolemia will need NS. The D5 will correct the hypernatremia. You will calculate the rate of D5 for the hypernatremia, and that rate will determine the hypernatremia. The NS is isoosmotic and will not worsen the hypernatremia.
So such cases, if we see in the ICU somebody with hypovolemia and hypernatremia,
Sure.
if we start correcting them for the hypernatremia alone, wouldn't the
No, so you don't. So again, if there is hypovolemia, you have to correct the volume. You wouldn't only correct hypernatremia. So hypovolemia in any situation, you have to give normal saline or the fluid, normal saline fluid. You could say that I am now, so let's say I have decided in my volume assessment that I need to give normal saline at 100 ml per hour.
okay.
And I want to give D5 at 100 ml per hour also for the hypernatremia, you could theoretically say I am going to give half NS at 200 an hour, and that will correct both. The problem with half NS in these kind of situations is if you want to give 150 of normal saline and 75 of D5, you can't do that with half NS. And so I would try in these situations give NS and D5 separately, and then adjust the NS for volume status and adjust the D5 for the hypernatremia and the correction that we are getting for the hypernatremia.
So say somebody with a sodium of 170 plus,
Sure.
we would you start with D5 alone first and then start correcting the hypovolemia, or would
No,
uh,
no, volume is always going to be first. So the body is telling you what is more important. The body, when it does ADH for volume, evolution is telling you volume is first priority. Always.
right? So that ADH has come for the
No, 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 इसमें ADH का कोई रोल ही नहीं है. हाइपरनेट्रीमिया में ADH का कोई रोल उस तरफ से नहीं है. Hypernatremia is due to volume loss, water loss.
right,
Water
and
loss, patient is not able to
brain.
take.
Yeah.
Yes. So ADH का इसमें कोई रोल नहीं है. Hypernatremia में तो ADH वैसे ही shut off है.
Mhm.
There is no ADH.
Right.
This is water loss that the confused patient, intubated patient, ventilated patient, whatever, can't get their hands on water, and we are not doing a good job, and we are not giving him the water also.
Right. So
Volume has to be corrected first.
my thought is like, wouldn't that D5 go inside, get mixed with all the sodium and become something more of a like uh, uh isotonic solution?
नहीं बनेगा. आपने D5 दिया है तो वो D5 ही रहेगा, वो पानी ही रहेगा. The 175 in the blood is also being matched by high osmolarity in the intracellular compartment, which is being driven by the potassium.
Right.
So there's
Yeah.
going to be a 170 ka potassium inside the cell. When you give them plain water, the plain water will predominantly go inside the cell. It will lower that, and then it will lower the osmolarity in the blood also. But
Okay.
it will distribute across 60-40.
And giving them a very high rate of D5 isn't going to correct the
Isn't going to correct their volume.
volume. Okay. Okay.
It is not going to correct their volume. No, 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 no. Because
Or-
like we said, intravascular volume तो 1/7 या 1/10, 1/12 ही रहेगा.
हाँ, it wouldn't be.
आपने 1 liter D5 भी दिया, तो
So
only
basically
1/12 of it, only 1/12 of it is intravascular.
okay, sir.
Yeah.
Thank you.
No problem.
Any more questions? No more? So thank you so much, sir. I think 2 back-to-back
Thank you.
classes, we had a double
And-
bonanza.
Yeah, thank you, and
Thank
best
you.
of luck to everyone for their exams, and we'll catch up next time.
Yes, sir. And with this, we take a break from the classes for this year. We'll start back in January. Thank you so much, sir. Happy New Year to everyone.
Thank you. Yeah, and Happy New Year to everyone.
Yes.